so much for these inspiring presentations. Before we end, we will have a Q&A session. So if anyone has questions, you can unmute yourself, or you can also put it in the chat box and I will read it out loud for us. But I will start with the comment from Rachel Ritvo, that we have two presenters from Psy-FI. Should we just mention what Psy-FI is?
You want me to mention what it is?
Yes, please. Thank
I
you.
appreciate it. Okay, so it stands for the Psychodynamic Faculty Initiative, Sci-Fi, and it's a program we started 7 years ago, where we take up to 6 people who want to be, who are mentees, who would like to find a mentor. They describe to us a problem or an issue or an area of study that they want to improve in, and we try to match them with a mentor of similar interests. And they work for about a year or a year and a half, developing their project and then presenting it to the group as a whole. And some amazing things are coming out of it. At first we thought we'd be getting mostly junior faculty, but it turns out senior faculty like to come back and work on something they've just not had a chance to focus on, but have been thinking about for years. We have people testing out using manualized dynamic therapies as an introduction to doing psychodynamic therapy. Horacio's worked with someone on community psychiatry, someone else on psychopharmacology and psychodynamics. We're working on an integrated core at the beginning, all that. So it's on the webpage at ACAP. Applications are due May 1st. And the hardest thing has been really getting the word out to people. Everybody keeps moving along, and you tell one group of people and they've moved on, and you need to tell another group of people. So if you have any questions, Horacio, Magda, or I could answer them, or Annika knows all about it. She helped set it up.
Thank you. And Annika did put that link in the chat. Oh, Dr. H, did you want to say something as a follow-up?
No. I mean, I'm really very happy to anybody who's interested can contact either Rachel or myself or Magdalena, and we can discuss a little bit more on what Sci-Fi is and how we worked all together.
There's a question: how do you take culture and diversity into consideration when designing therapy-focused research projects?
Basically, it's very important to study. I mean, when I came to this country, people would just refer me patients that would speak Spanish, because I speak Spanish. And I said, I don't want to see all patients that speak Spanish. I want to see everybody. I want to see patients from every sector of this whole country, fantastic country, African Americans, Asian Americans, everything. And then I prepared, if you guys are interested, in the YACAPAP site, we have the MOOC studies. And they're like two videos that I prepared on the characteristics of people from all the diverse culture all around the world. So I basically classified, people from each country and all the cultural characteristics of the population. So I guess, because I'm not a researcher, but I guess, if you start to look into the specific cultural characteristics of each diverse group, you will be even more prepared to do better research, because you'll have that embedded in your mind. So there are like two videos on that, on the MOOC series, and the YACAPAP on transcultural child psychiatry in the world that it's in the internet, if you're interested.
Can I make a quick comment on that too? And we haven't done this yet, but we're exploring with the regulation-focused psychotherapy that our mentee and mentor group are working on using as a training tool to consult with experts in child development in probably thinking about African-American children, because the disciplinary approaches are very much influenced by the by the socio-political cultural situation even more. And I think before just using off the shelf what was developed basically with white kids, consulting with parents in the given culture as to how they hear and see what it is you're proposing and whether it needs revisions, and testing those revisions to be more appropriate. You can't just jam it down people's throats. And then I thought the speaker a month ago who mentioned also you have to think about the life situation of the population you're working with, and can they get to treatment? You know, are they going to be able to participate and not drop out, and plan for that rather than having a failure because you've made it too hard. You know, you haven't understood the life circumstances. Getting the money to support that is another challenge. But we'll see.
Yeah.
We have oh, sorry. We have a question from Jennifer Lee, and this is directed to Dr. H. Can you comment more on how studying philosophy has changed the way you've approached your clinical practice and research? I know this is a big question, but I'd like to hear more and what you've learned from mentors.
Well, basically, I had people, this was my experience in England, where I had supervisors that were actually had their masters in literature and philosophy. So basically, they taught me how to really think in broad terms on how to understand the environment, the sociological aspects of you know, the civilizations, and you know, I you know, mostly how to be mostly curious and think about different dilemmas. Not just, you know, the conflicts, you know, that you see, but dilemmas in life and ethical problems as well. So it was all kind of a mix between Keats, who's a, you know, fantastic British writer, and you know, philosophers, you know, British philosophers, and even the Greeks. It was mostly the questioning life in a way. And when patients come to you and they question their own life, not just, you know, look into how you can approach them from the psychiatric side or from the psychodynamic side, but the questions of life when they tell you about spiritual things, and the, you know, if really, you know, God exists, and why they are in such bad shape if God exists, and they believe in God, and they're actually, God is there to help them, but he's not helping, things like that. It's besides a little bit of besides science. I would say that for me, science is number one, and analysis as well, and psychoanalysis as well, but also know, you know, things that are beyond science are also important. And today you can see that in alternative therapies. For example, for people with cancer, you have, I'm studying a little bit of physics and the quantum physics and the application of quantum physics into wellness. So this is like weird. This is something really new in these days. And I belong to a you know, organization that does that, and they're actually lectures on different alternative therapies that don't have to do with science as much, but with wellness. You know, so basically philosophy and literature are so important. Even when you read the literature or stories or books, they will interchange. What you read will actually connect with what you're seeing in sometimes in your patients, what you're seeing in conflicts with patients, the way you apply technique. Everything is interconnected. So that's how I see it. Sorry about the long answer. I don't know if that's clear or if I answered correctly for you.
And we have one more question from Rishabh Chawla. Oh, and then yeah, Jennifer Lee said, yes, that was great. Thank you. We have a question directed to Dr. Romanowitz. You had talked about the gray line between interventions that are evidence-based versus not. How does one advocate for therapies that lack evidence, but you have found to be beneficial with patients?
Yeah, that's a very complex question, Rashab. I think that could be a separate lecture. And thank you for this question. That's a very, very important question, I think. Kind of the, moving treatments from not evidence-based to evidence-based. Simply put, actually, it does not take a lot for a treatment to be considered evidence-based, which is worrisome on many levels. Essentially, you need, randomized controlled trial that shows that treatment is, statistically significant, better than a wait list or a no treatment. But the kind of the statistical significance does not have to translate into clinical significance. And so that is somewhat problematic. So it's kind of interesting, right? Like you were seeing in the clinic, oh, like I'm seeing a patient, the patient is doing better. Also, we need to define better, right? Because interesting, when we do research and we ask patients how satisfied are they with therapy, majority, at least in adult world, are satisfied with therapy, any kind of therapy, even non-evidence-based therapy, even if their symptoms are not improving at all. Like if you think about it, right, like you have somebody who's listening to you and is empathetic to you, that makes you feel good, but not necessarily, right, like your panic attacks might still be there and you might still be depressed. So it's a very, very complex question. But in terms of just like moving treatment from non-evidence to evidence-based, it is pretty simple. It's one trial, and you can compare it to a wait list, which essentially any kind of intervention typically is better than a wait list. So yes, it's kind of an interesting conceptualization that we have at this point in time, and we need to do better. That's why I came up with this idea of really kind of stole it from Kazin to create some kind of hierarchy. And also, I didn't talk about it, but we also need to come up with maybe better ways of measuring outcomes in psychotherapy, not only statistical significance or effect size, but also maybe clinical significance. How is this treatment helping the patient that is in front of us in terms of their clinical symptoms? So I don't know, Rachel, I think you want to add something to that.
Yeah, I can't resist, I suppose. There are a number of things. I mean, first thing, many more dynamic treatments are now evidence-based than they sort of get credit for, but you do have to match the standards somewhat to the research available. So if for a heart study, you want a huge number, but in child psychiatry, you're going to have to deal with really fairly small numbers of studies and small numbers of patients because nobody's funding big studies. I think we have to think about what gets grandfathered in or grandmothered in. I mean, in all of medicine, medications and treatments that have been done for a long time and that's seem to be effective, get continued even when new standards are brought in and then should get tested retrospectively. But I think, so there's a lot of evidence-informed treatments that might not meet a particular organization's established evidence-based definition. It's worth continuing to try to set up the control trials and to get the money. We do this in part rely on statistics because we have computers. Before you can see the rise in the demand for statistically proven things goes up dramatically when computers come along, because before that, the strongest evidence was observational and it was, had to be taken in. But if you really comb the literature, most of the evidence-based literature for psychodynamics is in Europe. It's not in the United States. And it's not in medical journals, it's in psychology journals. So I think we're finding with Sci-Fi that the membership of the Academy is woefully undereducated on really the volume of research that has been done in the last 20 years, the impact study in England, and the beginning to consider, are we looking at endpoints that are easy for us as doctors to measure? Is there DSM diagnosis change, or do we ask the patients and their families how they're feeling? Because it turned out, like with depressed adolescents, even if they still had symptoms of depression, that treatments that engaged them with other people, that they felt less isolated, those patients were much more satisfied with their outcome than patients whose symptoms had gone away entirely. They were no longer symptomatically depressed, but they still felt isolated and were really still kind of frustrated and disappointed. And that was a 3-arm study. So some of them were on meds, some on CBT, and some on dynamic. And they pretty much all came out the same. It was sort of all non-inferior to one another. But the question also is, are we practicing psychiatry without a psychology sometimes? And I think what the psychodynamic developers try to stick to is having some kind of psychological constructs and developmental psychological constructs that can be tested. And many of those are proving correct and even more elaborated, like you're talking about attachment, which is a psychoanalytic discovery and theory. And yet we keep finding, we're able more and more to flesh out the development. So it's exciting times, really.
Yeah, I think that that psychotherapy is coming back to the fore. I think I can see there was a question how to learn more psychotherapy, because in medical schools, they don't teach it. And many residencies, they don't teach it either. And so, but I'm at the Psychoanalytic Institute. The amount of applicants that we're having is incredible now. And I think that the phenomena that happened was that during the 90s, you got all this psychopharm eruption, and basically all the psychotherapy education, was nobody was paying attention to it. And now, you can see in the young attendings that really, what they do is mostly neuroscience and psychopharm. And they are missing how to connect with children. And that's what I'm actually teaching our trainees at Brown. So one of the things, if you're interested in psychotherapy, is to begin early. Really try to connect. First, see what kind of therapy you like. See what is your interest. Probably at first one doesn't know much of any of the psychotherapies, but it would be good to start to study a little bit of all of them, or the major ones, and then progress and get more knowledge. If you like more the psychodynamic piece, get in contact with the psychoanalytic institutes that are around your area. Some states do not have psychoanalytic institutes, but they have travel educators from the institutes. So it's good to really call and find out how you can learn that. And also in psychotherapy, probably it would be also good to talk to your program directors and see if they can bring people to teach. And one of the sci-fi's functions that Rachel and Mark and Dr. Drell and others are doing is actually that, to maybe mostly is to make sure that psychotherapy is not, it stays alive, because it's number one in the art of child and adolescent psychiatry, at least for me. Why would you go to child psychiatry just to give a medication only? And I give medications, but you give medications, the compliance on medications is even much better if you have a connection. So with a patient. So in a way, I think that the art of child psychiatry is really to study a little bit of everything, for my taste. Neuroscience, development. Many times development is not well studied and is left aside, and it's mostly just the diagnosis. And you can't be a child psychiatrist if you don't know good development and psychotherapy and studying research as well. So anyways, that's my take on that.
I just want to offer one more thing, and I tried to put it in the chat and accidentally erased it, so bear with me. We do, for scattershot introduction to psychodynamic ideas and others, we have a listserv that anybody can join. It's the listserv for psychodynamic enthusiasts.
Yeah.
It's called the Good Enough listserv at groups.io. But what you do is send me an email if you want to be on the listserv, or Magdalena, because we're the two administrators. It's not affiliated with any particular organization, although it sort of grew out of ACAP. So anybody can ask to join if they're a child mental health professional. And then I just transfer often from lists I'm on, events, that are distant virtual events that you can attend, like the ones at Austin Riggs. I mean, they're all over the country now. You can really dip into quite a few ideas online. And then we encourage people to join in with questions or recommending books, but we're still trying to get a critical mass going for that. So send me an email, or Magdalena, you probably have all her information from the postings for this.
And also you can find out in different institutes in the country, they have lots of lectures that you can do online, and there's education online as well in some institutes. So nowadays, after COVID, there's the boom of online education as well. So there's the good thing of this country compared to where Magdalena and I came is that it's full of resources. It's full of resources. It's a very rich country in resources, so use them.
Most of the evidence-based, the ones that have been tested, have websites too. I'm sure PCIT has a website, but MBT has a website. RFPC has a website. So, if you see a therapy mentioned somewhere, you go find its website.
And also you can connect with the American Psychological Association, which is really very good as well.
All right, thank you so much. I think if people have additional questions, please feel free to reach out to any of us, and you have Dr. H's contact information, as well as Dr. Romanowitz's email address, so you can reach out to them personally. So I just want to thank Dr. Romanowitz and Dr. H again for spending time with us today. It was a very enlightening session, and I'm sure there will be mentees reaching out to learn more from both of you. And thank you everyone for joining us and sticking with us till the end. Please mark your calendar for our upcoming session on Thursday, September 26th, featuring Dr. Dolores Bigfoot from the University of Oklahoma and Indian Country Child Trauma Center, who will be talking about research on cultural adaptations of evidence-based child mental health treatments. And I hope everyone has a good evening.
Thank you so much, everybody.
Thank you so much, everybody. Thank you.
Thank you.